Good morning. Good morning, everybody. Can you all hear me well? Students upstairs? Okay, great. It's wonderful to see this room very full like this. And it's very nice to see everybody. Welcome, everybody, to our second GMU Research Day. This is a great event for all of us. I am Najwa Zain Al-Abdin. I will be your host today. I'm a research assistant and a PhD student in precision medicine in the dual degree between GMU and Paris-Saclay. So I just want to remind you that during sessions, it's advisable to use the other door in order not to disturb the sessions. And also, I want to remind you that we have a closing ceremony tomorrow at 4 p.m. where there will be an award that will be given for the best posters and also recognition of faculty research achievements for each department. Very exciting. Okay, I will not talk much. I first want to introduce Professor Salim Shuaib, Director of Thumbay Research Institute for Precision Medicine and Vice Chancellor for Research, to come to stage.
So good morning, everyone. Dear Chancellor, dear Vice Chancellors and Deans, dear faculty members and students, and distinguished guests. As you all know, our university has always been at the forefront of innovation in medical education and healthcare. As research is the driving force behind medical advancement, research was integrated in the GMU strategic plan since 5 years. I believe that we were successful in differentiating our university as a research university with a very good attractiveness and a strong visibility. The organization of the Research Day is a reflection of our commitment to place multidisciplinary, comprehensive, and translational research in the center of medical education and healthcare. Without research, our understanding of disease process would remain stagnant and the treatment would fail to progress. The Research Day is held to showcase the world-class research project being actively carried out at Gulf Medical University. This annual event is an opportunity for staff and students to meet and share ongoing research projects and ideas to promote discussion and to strengthen collaboration across the university. The today event is comprised, as said by Nagwa, of a number of short oral presentation from faculty members, poster presentation, and we have also, at the end of the day, research awards. Dr. Rita from the Champalimaud Foundation is our guest today, and she will give keynote lectures. What are the main objectives of the Research Day? First, to create a venue for interdisciplinary collaboration between graduate students, faculty, and professionals from different disciplines in an atmosphere of educational excellence. Second, to explore research, ideas, and solutions, and share best practices among students, faculty, and professionals of our medical city. And finally, to discuss the current situation, challenges, and advancement of our students in relation of their research work. I would like to thank some people. Of course, the organizing committee for this Research Day, the CRC, and in particular, Dr. Rania, who took care of all the details of the organization of these 2 days. Thanks, Dr. Rania. I would like to thank Dr. Mohaddin Thombe, the president, and Professor Hussam Hamdi, the chancellor, for their continued trust, continuous support, and confidence in helping us to build an ambitious research environment. We hope that in the next coming years, we will continue to build on synergy and complementarity with international centers of excellence to be able to further maintain our high standards in education through research undertaken into pedagogy and education. And I will stop here. I would invite our Chancellor, Professor Hussam Hamdi.
Very good morning. I'm very pleased to inaugurate this wonderful day, wonderful 2 days of the research. And I would like to thank Professor Salim Shuaib, Vice Chancellor for Research. Thanks my colleagues, the Vice Chancellor, the Deans, faculty and the students for all the wonderful things they are doing it here. I would like to welcome Professor Rita Fior and Professor Anna Serta from the Champalimaud Center for the Unknown. Very interesting, the unknown. So we will learn about the unknown. We are here an academic health center. And I'm very pleased to see here Professor Fouzi, the medical director of the hospital, our main hospital, from the University Hospital, with us today, because it reflects the three pillars of an academic health center: education, research, and healthcare. And I think this is how we integrate this together. So research is not alone, medical education and research. And the type of research today, which are produced by all the colleges, led by the Institute of Precision Medicine, as a specialized center in the university, but the center interact with all the colleges, with all the programs at the undergraduate levels and at the postgraduate levels. So it plays a central piece in relation to research. When we talk about research, it is not only about biomedical research, but because we are known in the region in the area of medical education research, the whole science of education. Actually, for your knowledge, that 60% of the publication in medical education comes from Gulf Medical University in the region, 60%. And we can show you what we do. Maybe we can look into the zebrafish. So without any delay, we are looking forward to listen to the presentations, to listen and to interact and find, I think one of the main things is to find common areas of collaboration within the institution and across institution, within the country and from other countries. And this is a model which we like to have it here. And this is the value of having the Center of Champalimaud to establish this relation with Portugal and exchange experiences and work together. So I was talking to Professor Manda this morning, Dr. Salim. I think we need to have a proceeding of all what has been presented this year and maybe last year. And we will have it collected together as a proceeding. The same abstract, which is the same poster, which is presented to be proceeding. So to capture this and you can communicate it with others. Thank you very much. And inshallah, it will be a great success. Thank you.
So we are very pleased today to have Dr. Rita Fior for the keynote lectures. Dr. Rita obtained her PhD in 2007 from the Faculty of Medicine and Institute of Molecular Medicine. She had made significant contribution in the field of biology and developed pertinent experimental cancer models, including zebrafish. Since 2009, she is a leader project, and her team is cancer development and innate immune evasion at Champalimaud Foundation, Lisbon. Dr. Rita made a significant contribution in this domain, and she was awarded several times, and now she is the president of the Portuguese Society for Development Biology. She was elected, and currently she is an executive board member of the Zebrafish Disease Model Society. Dr. Rita has published several papers, including in PNAS, Cell, Nature Communication, Frontiers, and so many. So, Dr. Rita, welcome today to GMU, and we are very excited to listen to your talk.
We apologize, we have a technical problem. We just need a few seconds.
Okay, is this working? Hello? Now this is lost again. Okay, so is this working? Okay, sorry. Thank you so much. First of all, I'd like to thank the invitation to be here today, to Professor Salem and to everyone here. I don't know, I talk a bit low. Can you hear me? Sorry. Yes? Okay, okay, thank you. And thank you for the invitation to be here today and to talk about the work we are developing at the Champalima Foundation. So I'll start. So I always start with this slide, which is really to make a point. So, and I think here in Dubai, it's especially important because we are surrounded by amazing technology. We can go to the moon, we can sequence genomes every day, and we have amazing technology to study biology. But if you have cancer, there is no test to tell you whether the treatment is going to work and whether your tumor cells are sensitive to that treatment. So what happens, why is this, sorry, why is this moving? Anyway, so the idea is that we don't have a test to, before patients go to treatment, there is no test really to tell you whether tumor cells are sensitive or not to therapy. Because many times in therapeutical guidelines, there are several options of treatment and doctors don't know which one to give because these options of treatment were defined in large clinical trials with many patients, and then you have average of response rates. So you can have 70% of response rate to a treatment, but if you're a patient, you don't know whether you're going to be in the 70% that respond on the 30% that do not respond. So patients go through trial and error approaches to find the best treatment today, although we have this amazing technology. So that's why I started developing the zebrafish avatars or zebrafish patient-derived xenografts. So what are these? These are patient-derived xenografts where we take tumor cells from patients and we inject it in little zebrafish embryos, and I'll show in a minute. So when I started this work, really the gold standard in the field was to do exactly the same, take tumor cells from patients and put it in mice. And mouse patient-derived xenografts have been shown to be highly predictive of the response in patients. And it's really the gold standard in the field. However, they take months to develop and patients do not have that time to wait for the results of the mice. So we started developing a very short assay, but an in vivo assay. So it's in the middle between the in vitro organoids and the mouse model. So we take tumor cells from patients, we label them fluorescently and microinject little zebrafish embryos, which I'll show in a minute. And then we start treatment within 3 days of treatment. And then these treatments can be either radiotherapy or chemotherapy or biological therapies. So we can take zebrafish embryos also to the radiotherapy machine where patients are being treated. And the idea is that after 3 days of treatment, we can assess whether these drugs were able to induce cell death, reduce the tumor size, or if impacted on angiogenesis and metastasis, and I'll show you in a minute. So our big goal is really to develop this test and help MDs choose the best option for their patient. And this test is developed to be performed in around 10 days, 2 weeks maximum, which is also the time that most patients have to wait for all the CT scans, all the analysis and so on. So it's developed to be performed in a short time, although the 2 weeks, okay? So more or less, this is what we're trying to do. So I'll show you this video for people who don't know about zebrafish. So these are zebrafish embryos of 2 days post-fertilization. So they're really small, so we're reducing the scale, and that allows us to take the tumor samples from patients and do hundreds of avatars, okay? Because we are reducing the scale. So you need to anesthetize these fish. And here is Mayra, she's a PhD student in the lab, she already finished, and she's going to show you how we microinject tumor cells into zebrafish embryos under the stereoscope, okay? Also, we take tumor cells directly from patients and we do not amplify in vitro. We want to avoid the caveats of growing tumor cells in vitro and all the selection. So here is the eye of the fish, the heart beating, and here is where we microinject the tumor cells, the fluorescent tumor cells, in the perivitreal space of the fish, okay? So we can microinject around 200 fish per hour. And this is really the power of the model, and also because it's transparent, and I'll show you more. So after treating the zebrafish embryos, these avatars, what we do is an immunofluorescence and go to a confocal microscope to have single cell resolution. So we can use also transgenic zebrafish embryos that, for instance, label blood vessels. So we can look at angiogenesis, for instance, and other behaviors of cancer in vivo. So we do an immunofluorescence, and then we can zoom in into the tumor and have this single cell resolution that allow us to look inside the tumors and see what's happening. Okay, so we had to show that, in fact, human tumor cells were able to proliferate in the fish, otherwise we do not have a model. So here is a 2-hour pulse of EDU that intercalates in the DNA when cells are replicating. So this really shows that human tumor cells are able to proliferate inside the zebrafish. We can also see an example here of a triple negative breast cancer that was able to recruit blood vessels from the zebrafish host. So this is highly conserved processes. So the fish is really reading the signals from the human tumor cells and recruiting tumor vessels to the tumor. We can also see micrometastasis formation in the fish. So tumor cells can migrate to distant sites like the brain, the retina, the gills, or even the tail of the fish, okay? So we can also study metastasis. And we can study it live. So we can take the fish with the tumor cells live into a microscope and look live what's happening to these cells. So in red, you have tumor cells, and in green is the vasculature of the zebrafish embryo. And we can see how cells are behaving, how do they migrate, how do they push, how do they extravasate. So you can really study biology also with this model. Okay, so in the last years, we've been developing several models of cancer. We focused mostly on colorectal cancers, where we started, rectal cancer, where we are studying how to see if the model can tell us whether tumor cells are sensitive or resistant to radiotherapy, for instance. So we can select patients that are resistant to radiotherapy so they don't have to go through radiotherapy and they can go directly to surgery. Pancreatic cancer, stomach cancer, breast cancer, ovarian, bladder, and also glioblastoma now. And we also developed protocols for several targeted therapies like cetuximab, bevacizumab, and for instance, olaparib. And really, this project is really only possible through the close collaboration that we have with the clinicians, with the physicists and the radiologists and pathologists and everyone involved, and oncologists. So it's been a really multidisciplinary work where we collaborate a lot with the hospital at the Champalimo Foundation, but also other hospitals in Lisbon. Okay, so I'm going quite fast here because this is published, but it's really to show you an example of these international guidelines of cancer. So we have the NCCN, the American, or the ESMO, which are the gold standard guidelines. And you can see every time you see or, so this is for colorectal cancer as an example, it's an equivalent option, okay, for medical doctors to choose to their patients. The only one that has a biomarker is cetuximab, panitumumab, that has KRAS mutation as a biomarker. Otherwise, everything is equivalent, okay? And what happens is if patients are treated with FOLFOX, it doesn't work, it goes to FOLFIRI. If they start with FOLFIRI, it doesn't work, they go to FOLFOX, and then they go to third line. So meaning these two arms, FOLFOX and FOLFIRI, are very equivalent in colorectal cancer. So in this work, what we did was really to start and challenge the model and see if the zebrafish model could actually distinguish different responses to therapy, could show different behaviors of heterogeneity of these different cancers. And so this is what we showed here in 2017. And this is just to give you an example of what we do in the lab and how do we analyze the data. Okay, so what we do is generate the avatars of xenografts, And then we treat them. We have always a group of controls, no treatment, and then FOLFOX, for instance, and FOLFIRI. And what we analyze is the induction of apoptosis, cell death, whether this chemotherapy induces or not cell death. And what we do, we use activated caspase-3 as a marker of apoptosis, and then we quantify this induction of apoptosis. And here, each dot here is a xenograph, which allows us to do statistics. So I hope you can appreciate that FOLFIRI is much more efficient at inducing apoptosis than FOLFOX in this cell line, meaning that although they are equivalent, their efficiency in killing tumor cells is different and can be absolutely tumor dependent, and we show that. In this work, we also showed that we saw similar responses between the zebrafish model and the mouse model. We also show then in patients, first with cell lines and then patients, where we showed that we could predict 4 out of 5 patients' responses in zebrafish. But now I'm going to show you our last data that we are wrapping up for publications. So now we have 55 patients, and this work has been really spearheaded by a postdoc in the lab, Bruna Costa. And so what we've done was really to do what I call a co-clinical study, okay? So we need to show that the model is really predictive of the response in the patient, of the patient's clinical response. Otherwise, we don't have a model for personalized medicine. So we are really validating the model as much as we can. So what we did, we have 55 patients that went to surgery, and after surgery, they underwent adjuvant chemotherapy, meaning they got therapy to reduce their chances of having a relapse, okay? So, but some patients really maintain stable disease, so they do not progress, so chemo works, or some patients progress under chemo or after that because the chemo really didn't work. So what we do is take the tumor cells from the patients, we label them fluorescently and generate the avatars. And what we do, we have the controls, and then we give exactly the same chemo as the patient had. And so the idea is to see if we can match the results from the avatar and the patient to see the predictive value of the model. So this is what we've done here in the last years. So I'll show you some examples. So this is an example of a patient that were stable after adjuvant chemotherapy, and it was treated with capox. And as you can see, it was inducing apoptosis. We saw an induction of apoptosis in these avatars from the patient, and the patient was stable, did not progress. This is another example of a patient that actually progressed under treatment, but their avatar did not respond to chemotherapy. So this is what we call a match, where the result in the avatar was corresponding with the patient result. So now if we plot them all together and we separate patients that were stable from patients that progressed, we can see the fold induction of activated caspase. So how much did the drug induce apoptosis in the tumor cells? And as you can see, patients who were stable, did not progress, their avatars responded to the chemotherapy that were given to those patients. So now what we tried to do was to do a ROC curve to define which could be the best threshold to define sensitivity or resistance in our test. And it's not working. So we could define a threshold of 134 fold induction of apoptosis that defines sensitivity or resistance to the therapy. Now, if we plot this in a confusion table, we get a positive predictive value of 92% and a negative predictive value of 71%, meaning that we can match most of the patients that were stable, did not progress, their avatar was sensitive to therapy. And most of the patients that actually progressed, their avatar was resistant to therapy. So we are really excited with these results that actually show that the avatar model, the zebrafish avatar model, has a really great predictive value. So now what we did was really to plot now the progression-free survival of these patients. So what happens if we separate now patients by patients whose avatars were higher than 134, so they were sensitive to therapy, from patients that their avatar were resistant, lower than 134. So the drug did not induce apoptosis. And it's very clear. So patients whose avatar responded to therapy have a much higher progression-free survival than patients whose avatar did not respond. So actually, this is showing that chemotherapy works, and that's why it's given to patients, is really that it works and reduces the chances of a relapse. If we now plot the stages separately, because we have 55 patients and a mixture of stages, we can still see the effect and a significant impact on progression-free survival. Okay. So now in breast cancer, we also did the same co-clinical study. We have less patients, but now we have 100% predictive value, positive and negative predictive value. So we can distinguish the patients that respond to therapy from the patients that do not respond to therapy. What we cannot do in breast cancer is really to distinguish pathological complete response from a partial response. Partial responses in neoadjuvant treatment in breast cancer are very heterogeneous. You can have a partial response of 98% or 99% or 60%, and that we cannot distinguish, but we can distinguish between responders and non-responders, which is really exciting. So this work is spearheaded by Raquel Mendes with another postdoc in the lab, and we also wrapping up for publication. So these results have been really promising, so are taking us to the next level, which is really not working, sorry, well.
We have designed a clinical trial in which breast and ovarian.
Okay, can we take out the noise, the sound? So it will be confusing. So we designed a clinical trial. I'm starting. We designed the clinical trial, which is really the next step, where we're going to take, we're going to focus on metastatic breast cancer and ovarian cancer patients. And we're going to randomize patients in control and trial. And the difference is that the control will be treated as the standard of care by the oncologist. So they'll choose the treatment just like it's done with standard of care with no test. And the other group of patients will be treated according to the avatar test. Okay, so this is the only difference between the two groups. This is not working. Okay, sorry. So we'll be focusing on metastatic breast cancer and metastatic ovarian cancer patients that have ascitic fluid or pleural effusions. So this is advanced stage. Why are we focusing in these patients? Because we found out that with these liquids that have to be taken from patients and are full of tumor cells, and these liquids are trashed. These are medical waste. So we can use for the trial and do not do an additional procedure to patients. So these patients have these liquids which are highly symptomatic. They need to be taken out to relieve the symptoms. And so, but usually they're trashed. And we can use these medical waste to generate avatars. So the idea is that the patient goes to an oncology appointment. The oncologist will define which are the options for that patient according to the guidelines, according to their comorbidities, and we'll have to register which are these options, because in these advanced stages, sometimes there are like 7 equivalent options for that patient, and the doctor has no test to tell them where to go. So the doctor will define which are the options for that patient, and then patients will be randomized in these two groups. One will go to the standard of care, so we'll have the oncologist choice, and the others will go to the zebrafish avatar test. But we are going only to test the options that the oncologist defined previously. So we're not going to give different drugs or new drugs. It will be the ones that are in the guidelines, okay, and not new drugs. So the difference, and then we want to compare the overall survival, the progression-free survival of these two groups of patients. And our preliminary data from real-life data is telling us that we might see like almost 3 times difference in overall survival of these groups of patients. And simply by optimizing treatments that are now in the clinic. So it's not new treatments, but it's really optimizing the treatments, giving the right treatment to the right patients. And this is really our big goal in the lab. Okay, so this is part, so my lab has 2 arms of research. This was one arm, which is a major goal in the lab. And the other arm of the lab, research arm, is really different. And it's more fundamental biology, where we're trying to understand the interactions between the tumor cells and the innate tumor microenvironment, okay? And we're trying to understand how cells crosstalk and how this is regulated using the zebrafish model. Okay, why did I start it? Oh, well, this goes, sorry. This is moving. Okay, thank you. Okay, why did I start thinking about this? So when I was developing the model, I saw that we could inject human tumor cells in the fish, and then after 4 days, we still have the tumor. Okay, this is normal. We have only innate immunity. We don't have adaptive immunity at play in the zebrafish model at this stage, because we are using embryonic stages very early where adaptive immunity is still not developed. And so we thought we do not have rejection. And in fact, we didn't. So in 4 days, 100% of the fish still have a tumor, just a very short assay. But then we had other human tumor cells that after 4 days simply disappeared from the fish. They were wiped out from the fish. And so people were saying, well, this is a fish model. You know, the human tumor cells are not able to survive in the fish. This is lack of survival factors, and your model is not good. But I didn't think so, because we had several, I think, cues that could tell us that maybe there was a different story. This is not playing. Can you play it, please? So, cannot play. Okay, so I'll tell you what we could see here. This is the problem of not having my computer. So, okay, so what we saw was that you could see human tumor cells in circulation being chased by myeloid cells, neutrophils, and macrophages that were chasing these human tumor cells and trying to phagocyte them. But we could also see other cells that were invisible to the immune system. So really, this generated an hypothesis that maybe we have human tumor cells that are able to escape the innate immune system and some other human tumor cells that were still being recognized by the zebrafish immune system. This is strange noise. Okay, so we wanted to test this hypothesis, and we focused in these two human cancer cell lines that had these completely opposing phenotypes. So one was being rejected and the other one was not, and they were both coming from the same patients. Okay, so we had 2 examples of human tumor cells that came from the same patient with this completely of opposite phenotype. And that's why also this was another piece of evidence that maybe it was not just survival cues, okay, that were missing from the zebrafish embryo. So we focus on these 2 cell lines to try to understand what was happening here. So another advantage of the fish is that we can play around with the cells and label them, for instance, with different colors and then mix them together. So the idea was, if 620s are able to escape the immune system, maybe if we put them together, one will protect the other from being rejected, or will it become dominant over the tumor microenvironment and it has more to do with proliferation capacity and so on. So what we did was to inject 480s alone with the ones that are rejected. As you can see much of the tumor, but you still have some scapers that engraft. So we call engraftment or implantation the presence of fish with tumors at 4 days, and 620, almost 100% of the fish form a tumor. So what happens when we put them together in the same fish? When we put them together, the 2 types of cells in the same fish, what we see is that 480 now goes to the double, so can implant the double of the times in the xenografts, but 620 goes down, so it's also affected. And then if we look at each xenograph, we still have both cell lines. So it was not like 620 became dominant over 480s. Both are still present in the xenographs, okay? Suggesting that really maybe 620s are able to protect somehow 480s from being cleared. So next, what we did, and this work was spearheaded by Wanda Povo in the lab, also a PhD student in the lab, she already finished. And what she did was really to characterize the tumor microenvironments. And I hope you can appreciate here. So what we did was to quantify neutrophils and macrophages in the tumor microenvironment, quantify the number of cells, so we can use transgenic zebrafish lines that label these myeloid compartment, and we can distinguish which are neutrophils and macrophage with these transgenic lines. And what we see here is that 480s recruit much more neutrophils and macrophages than 620. But what was cool was when we mix them together, the tumor microenvironment becomes very similar to 620. So 620 seems to be dominant and showing the microenvironment of the mix and suggesting again that 620 might be able to block the recruitment of these innate immune cells. Okay, then what we want to look was to see if the human tumor cells were being able to modulate the tumor microenvironment, and we wanted to see if we could see differences in macrophage polarization. So I don't know if everyone is aware, but macrophages can have different states, and they can be pro-tumoral or anti-tumoral depending on the molecules they're expressing. Sorry, this went on, has its own thing, so it can go when it wants. So what we look at is TNF expression, which really, when they're TNF positive, they're more inflammatory. When they're TNF negative, they're more pro-tumoral. That's the idea of the polarization states. So I hope you can see here that 480s, the ones that are being rejected, generate a tumor microenvironment much more inflammatory, much more M1-like macrophages are present in the 480 tumor microenvironment, whereas 620, you see a predominance of M2-like macrophages, TNF negative. So really, this shows us that when we put human tumor cells in the fish, the fish can generate different tumor microenvironments, or the human tumor cells can generate different tumor microenvironments, because really the fish is reading, we think the fish is reading the signals that are coming from the human tumor cells. So it's like a reporter of the state of the tumor microenvironment. So then we had to show that this was really that the phenotype that we were seeing, the clearance phenotype or the implantation phenotype, was dependent on these cells. And for that, we used hypomorphs mutants in zebrafish that have low macrophages and low neutrophils, and we saw an increase in the implantation. Here I'm just showing another experiment just to show the same, that we use L-clodronate, which chemically ablates all macrophages. So here in the controls, you can see macrophages now in red, and they're being recruited to the tumor that now is in green, the 480s tumors. You can see the recruitment. LPBS is the control, but when we inject L-clodronate, you don't see any more macrophages, so they were ablated. And when they're ablated, tumors are much bigger, and implantation goes to 100%. So showing that our phenotype was really dependent on innate immunity and this response of the fish in trying to clear the tumors. But this is totally tumor specific, and is showing us that the fish is responding differently to the different cues of the tumor, okay? Then we wanted to do an immunoediting experiment in zebrafish. So this is one of my favorite experiments. Where we did was to microinject the parental tumor cells, 480s. 1 day post-injection, all the fish have a tumor, it's fine. But then after time, 4 days, what we see is that 80% of the fish, they get cleared, no more tumors. But 20% still have a tumor, okay? So what we did was to dissect these tumors, put them in culture, and see if what happens if we microinject again these tumor cells that were selected in the fish and escaped the first injection time. And as you can see, in fact, what we saw was the escapers made much bigger tumors, implanted much better, and also recruited less macrophages. Okay. So then reviewers wanted to know what are the signals, what is really playing here, which molecules are really being selected and driving this process. But I didn't really want to sequence those escaper tumors because they were in culture for 2 months. So everything can change. So we designed a different experiment where we microinjected again this SW480 parental cells. 1 day post-injection, we dissected these tumors for single-cell RNA-seq, and then at 4 days, we dissected the escaper tumors, okay, for single-cell RNA-seq. And I hope you can appreciate here that 1 day post-injection, we have a lot of diversity of different subclones of these tumors, okay? And then at 4 days, what happens is that some subclones just completely disappear, they're cleared, but some other subclones expand in the fish, okay? They are selected. If we look at the pathways, what we see is that the major clone that disappears is highly enriched in Notch signaling, but also interferon gamma, and the clone that mostly expands is really enriched in Wnt signaling and IL-10 signature. So now we're trying to understand more the signals and more the molecules that are really governing this, all these editing and interactions between innate immune cells. Okay, so I'm going to the last story just to tell you also another example that we have in the lab where we tried to see if the zebrafish model could also be a good model to test immunotherapy. Okay, because we were seeing that we were being able to look at the interactions between innate immune cells and the tumor microenvironment. And it looked like, or at least this is my hypothesis, that maybe the zebrafish is giving us a reporter of the state of the tumors, of the tumor microenvironment. And the idea is that if we have a tumor that is still being recognized by innate immunity, maybe these are the patients that are eligible for immunotherapy, because these tumors will be more easy to go in and immune checkpoints, for instance, be used. But at the time, we didn't have access to samples that then went to immunotherapy. So I tried to find a model that could be useful for us to test this hypothesis. And we started the bladder cancer model because bladder cancer is treated with the oldest immunotherapy, which is BCG vaccine. And BCG, although is adaptive immunity based, the first responses are also innate immune based, and innate immunity has a major role. So Mayra in the lab, also PhD student, she also developed this model. So what she does is to microinject bladder cancer cells, and then at 1 day post-injection, embryos are separated in 2 groups, xenografts are separated in 2 groups, ones that will be injected with BCG and the others will be injected with PBS. Then after 2 days, 3 days post-injection, there will be a second boost of BCG or a second boost of PBS control. And what we do is to analyze it 4 days post-injection. So again, a very short assay. And what Mayra saw was, in fact, that BCG and BCG booster together, they really increase clearance. So now we are plotting clearance instead of implantation. So clearance is rejection. So if we inject BCG, we go from 30% of clearance to 54% of clearance. So we lose tumors in the fish, which is the big goal of the therapy. And we also can see an induction of apoptosis upon BCG injection. And we don't have adaptive immunity, only innate immunity. And so what Mayra did was, again, to characterize the tumor microenvironment. And what she saw was that BCG induces a massive recruitment of macrophages to the tumor, and also that BCG is able to switch the polarization state of macrophages. So you can see here with PBS, you have much more M2-like macrophages, so TNF negative, but then when we inject BCG, this switches and we have much more M1-like TNF positive macrophages, showing that BCG is inducing this difference in the tumor microenvironment. So we established also a collaboration with Professor Stefan Kaufmann, who's a specialist in tuberculosis, and he is developing a new vaccine. So we established this collaboration and tried to see if the model could differentiate between the conventional BCG and the new genetically modified BCG. And yes, we did see a difference in phenotype. So the model has resolution to look at this difference in new vaccine efficiency. But now I'm just going to show you what also we can look in the fish, which is study live all these interactions. And that is the powerful, I think the most powerful and beautiful part of the model, is that we can see live what's happening and try to understand these interactions between tumor cell and macrophages. So in green, you have macrophages, and in red, tumor cells. And this is a movie that Mayra did in the light sheet microscope. And then what she did was really to analyze then the interactions between the tumor cells and innate immunity, in this case, macrophages. And what was really cool was that BCG or VPM, this newly modified BCG vaccine, they completely change the behavior of macrophages. So in controls, you see a lot of dendritic-like macrophages that are just surveilling. But if you inject the vaccine, what happens is they become round and not so much dendritic. They increase their phagocytic activity, and they start phagocyting all the tumor cells. But what was really cool was also to look at interactions between the macrophages themselves. So macrophages start touching each other a lot upon vaccine injection. And what was really cool was the VPM increases also the fusion between macrophages, which is a reminiscence of the formation of a granuloma, which is typical in tuberculosis. So we thought these results were really, really cool. So basically my lab in this second arm of research is really trying to explore also these interactions between tumor cells and innate immunity. We're trying to find new molecules, FDA-approved molecules that can boost this rejection. The idea is that these molecules then can be combined with immune checkpoint therapies to increase efficiency of immune checkpoint therapies, because the idea is that sometimes the immune checkpoint therapy might not be working because of other innate immune repression mechanisms in the tumor. And maybe if we have these drugs that can switch the tumor microenvironment, the innate tumor microenvironment, this could help adaptive immunity. And we're trying also to find out which are the molecules that stop, that don't eat me signals, that block this recruitment, and trying to understand more these interactions between human tumor cells and innate immunity. Okay, so I just want to thank, this is not working, the people from my lab. They're there. So it's a great team full of girls, only girls. So, so it's a girl teams. And well, sometimes we have a guy there, but he's not there anymore. And we'd like to thank all the former students, collaborators, reagents, all our units, support units, and the Champalimau Foundation, especially the FISH platform. Of course, we need them a lot, but imaging, biobank, all our collaborators from the clinic. And I would like to also to thank my mentors, funding, and you for listening. Thank you very much. Sorry for this presentation confusion.
Thank you, Dr. Rita, for this very exciting talk.
Thank
I am
you.
sure that you will have a lot of questions.
Thank you.
Any questions to Dr. Rita?
By seniority.
Of course, indeed.
This is amazing research.
Okay, thank you.
Although I'm not a biologist, but as a surgeon, I look at it from clinical perspective, and you have seen a real model of translational research and how it will influence the management of cancer and take very important decisions of whether to give chemotherapy or other modality, or there is no need to do that because there will be no response, and you get the results in 4 or 5 days, 1 week,
10 days.
10 days. That's
But yes.
amazing. And you have been focusing more on the advanced cancer in a way.
We also have data on early cancer. For
Yeah.
instance, in breast cancer, we have half of the data is neoadjuvant treatment, so before surgery, and so early stages also.
Because this was my point, many women, they don't want to, particularly early cancer breast with estrogen progesterone receptor positive, receptor negative, and they don't want to take chemotherapy, and they will have surgery. So do you think doing this, taking the tumor and put it in the zebrafish and see that the chemotherapy will not work, so they don't take the chemotherapy?
I think that should be the future, I think. But I don't know if doctors will be willing to do that. I don't know if patients will like. I think this will be, but I think that's the purpose of it. Even for rectal cancer, radiotherapy, exactly the same thing. So there are patients that go through radiotherapy and the tumors do not respond. So they're subjected to radiotherapy and then they go to surgery. So these patients maybe should go to surgery directly, or patients that really respond very well to radiotherapy, these patients go to a watch and wait program where they don't have to go through surgery. So it's really to try to help the choices. Yes, I think the model, I hope that one day we'll be really able to help patients and doctors decide the best treatment and to optimize treatments. Because with ovarian cancer and these metastatic ovarian cancer with the ascitic fluids, so we started seeing that we could use this medical waste products to do the xenografts without biopsy or surgery, without additional procedures. And this was very exciting because we could do hundreds of avatars and test different drugs. And when we wrote the clinical trial, there were no data, no real life data of these patients. So to try to calculate the population size was very difficult. We didn't have an idea whether giving the right treatment to the right patient would actually have an impact on the overall survival of these patients, because these are advanced patients, so on. But then I had an oncologist in my lab doing an internship, and she went to the real data to try to find out what happened to patients of this advanced stage if they responded well to treatment, and patients from this advanced stage that did not respond well to treatment. And the difference was 3 times the overall survival, meaning with the treatments we have today, if we optimize them, we can improve a lot the overall survival of many, many patients. Of course, if we have new drugs that are better, we should use them. And I'm not saying that, and we should introduce them, of course. I'm just saying with what we have, we can do much better. And I think with a test like this could help a lot. That's our goal, really.
Okay, Dr. Fawzi.
What is the response of the physicians?
What?
What is the response of the physician to your studies? Have they start to respond? They start to implement what do you think that it's giving a positive results?
I don't know if I understood very well your question, but is what are the ideas of the physicians and if the oncologists are adhering? So it's been very fantastic. I think the collaborations with clinicians, they're very happy to collaborate, and we have many projects. But I only have a few that ask me for a test, but I already had some. And that's when I realized that we really need the clinical trial to show that if we have the choice being done by a physician or by a test is actually different. And that's why we're going to the randomized clinical trial, which I think is the mandatory step for the clinicians to really adhere to this idea, and for this to one day maybe go to guidelines, which is our goal, or organoids also out there. But still, I still believe that we have here an in vivo model, which I like most. And I'm a developmental biologist by training, so I believe a lot in evolution and an in vivo model but organoids are also there, and I think they will also help a lot in this. And I think I hope soon we'll have a test, either it's a zebrafish or organoid or both, but at least a test so patients are not experimenting. I think that's the big goal. I don't know if I answered your question.
I could see that only few physicians
few.
have sent
The samples, but yeah,
What do you think
the constraints.
barrier, yeah, what
I
do
don't
you
know. And I don't understand because we are testing the guidelines. The options are in the guidelines. So I don't understand.
think? Is it just resistance to
I think-
change, or
I think so, also because it's not in the guidelines, it's not approved. And I think
okay.
they're afraid of that. I don't know. I don't know. I believe that if I was in the US, maybe it would be different. In
So
Portugal,
last question
We're
by
still
Dr.
like
Fawzi.
that.
Last one.
My
there
third-
were students also. They would like to have questions.
My
Yeah,
third
yeah.
question is the response to statistics. The fantastic response to the test on the breast cancer. Positive predictive value 100% and negative predictive value 100%. But the first one shows
Colorectal
the
cancer.
negative predictive value 70%. Means that when you say this doesn't work, maybe some of these will work. So how would you reconcile that?
Okay, so I didn't show that because it was complicated to explain. So, and we're wrapping up the paper. So what did we saw? In colorectal cancer, most of these patients are all adjuvant treatment. So sometimes you have surgery and you can have a surgery that is highly efficient and there is no circulating tumor cells. So the patient will not progress, and it's not because chemo worked or did not work. That's one confounding effect. But then what we did was a multivariate analysis with all our data and all the other parameters that we look at. And the multivariate analysis, what it showed us was that caspase-3 apoptosis was the most predictive parameter for sure. So if we look at apoptosis, this is what we have. But then we did a more thorough analysis to see if other parameters could be interesting. And what we saw was that now if we divide stage 2, 3, early stages of colorectal cancer from stage 4, and now we do a ROC curve for apoptosis, we have different thresholds. Okay, so the test is different according to the stage. And then what we saw was if in stage 4, we analyze the metastatic potential, then we improve the positive predictive value and the negative predictive value. Meaning, what we think is happening is that you have tumors that, for instance, if they do not respond to therapy, we saw in the avatar a non-responder, so a negative, but if they don't have metastatic potential, they will not progress. So we saw that the tumor, the ones that were not matching, if we now input their metastatic potential, because we inject tumor cells in the fish, and we can also quantify the potential of these cells to do micrometastasis. And we saw that in stage 2, 3, most of the avatars did not form metastases, and in stage 4, most of the avatars formed metastases, but some did not. And these are the ones that were the no match. So we could improve the predictive value, the negative predictive value, if we now put another parameter in the analysis. So what I think, well, trying to sum up, what I think is related to the context where we are looking at adjuvant treatment and there are confounding effects because it's after surgery, bulk surgery. And also we have to take in account not only the sensitivity of the cells to treatment, but also their potential to metastasize. So it's these both things together that will tell you whether the patient will progress or not. This is what we feel. And in breast, half of the patients are in the neoadjuvant setting. So I think it has to do with that. But we're also looking at metastases, and it's also maybe a prognosis. So if we do not see metastasis in the avatar, we believe it's a good prognosis for the patient. This is what we are looking at. Okay.
Okay, more question, Jose?
My name is Sam. I am Hi, my name is Hussam. I am the cellular imaging in charge in Tombe Research Institute, as well as a PhD student here. So I would like to ask about hypoxia as a major rule in the tumor microenvironment. Have you checked the tumor injected in the xenograft if it developed any hypoxic conditions there? If so, how did you do that? The other question, the other part, have you studied also the NK cell mediated in zebrafish, or it was just macrophages?
Until now, neutrophils and macrophages. We would like to have a NK transgenic, but we don't. And I tried, the antibody is not working, so we need a transgenic that labels the NK cell because they exist. They come a bit later, but they might be coming earlier in the context of the tumor. Regarding your first question, hypoxia, these tumors are small. So they're around 200 microns, 130 microns of diameter. So we didn't look much into hypoxia because I don't think it is a major play because the tumors are still within the range of the size that I don't think hypoxia is playing a major role, but we can look at that in zebrafish. There are several probes, so it's possible to look at that, but we haven't done that.
Okay.
But it's possible.
Me? Okay.
Yeah.
I have a question. So we know the tumor is heterogeneous in time. And as you just mentioned, the tumor is very small. So how can you ensure that you have managed to capture the heterogeneity of that tumor? Because in chemotherapy, it works partially, as you have mentioned, or fully. And even as you have shown in your PCA analysis, there are subpopulations in that. So like, how could you like ensure that you have captured the heterogeneity? Because only then can chemotherapy work, I would say.
So yes, we're sampling the tumor, right? So we take a sample of the tumor and we mix everything together and we inject. So we have numbers and there is a limit there. So there will be always this caveat. If the tumor is highly heterogeneous and we get a sample from a region that is not representative of the tumor, it is what it is. We have to deal with that. It's like doing a biopsy and not taking the right part of the tumor. So exactly the same. So we're totally depending on the tumor cells, on the sample that we get. If we don't get enough tumor cells, we have no test. And what can I tell you is that I can tell you the predictive value is pretty good. So I'm happy with that. Okay.
If no more question, we will stop.
One last technical thing. You get the biopsy from the surgeon or
Yeah,
a tissue after operation.
exactly. And then what we do, we take this sample, we chop, and we pass through, and then we cryopreserve. We can cryopreserve the samples, okay? Then the day that we inject, we take these samples, we process it, pass it through a filter and inject. So we don't grow them, we don't do organoids, we don't pass them in vitro. So we take the tumor cells and the microenvironment into the fish, including the tumor microenvironment.
But
Okay.
you can take also culture cells.
We can, yes, you usually, every time we start a new model, we start with cell lines, human cell lines, and then we go to the patients. But when we get patient samples, we take everything from the tumor. We do not select the tumor cells. We do not select anything. We try not to select. We try to inject everything from the tumor, the mix from tumor and its microenvironment into the fish. I don't know if this is helping the question of the heterogeneity of the tumor, because we're not selecting only for the tumor cells. We're putting everything inside the fish. Fibroblasts, endothelial cells, macrophages, whatever it is, T cells, if they're there, they'll go to the xenograft. And we like that because we want to try to maintain the tumor.
We can, from what you're saying, we can ask surgeons in the country here to send us the biopsies or
Yes,
tumor, and we process it.
Yes.
And use it in our zebrafish.
exactly, you can. That's the idea. And if you are doing a research project first or whatever to send samples, we received samples from Sweden, for instance, cryopreserved bladder cancer patient samples that we received in Portugal that were cryopreserved and sent to us, for instance. Need to process them immediately after the surgery, after the biopsy. So it has a short time window, like everything that is to cryopreserve them. They need to be not snap freeze. But it's a very simple protocol, very simple. The cryopreservation.
Okay, okay, last question.
It was very interesting presentation. I just want to know, because you have used caspase-3 induced apoptosis. So it's a basis for knock-in and knockout gene for CRISPR technology also. So was it very similar to that? Because they are deleting genes for the cancer cells.
Who?
It's a CRISPR technology which has been used these days for knocking in and knocking out genes
Yes.
for the cancer treatment.
So
And they also
what
are
is your
using
question?
caspase-3, especially for inducing apoptosis, to
Okay.
eliminate those cancer genes.
Okay, so I don't understand. What is your question?
So is the caspase-3 has?
No, the caspase-3 here is just a readout of apoptosis. So when cancer cells, upon drug treatment, if the drug works, they will induce activated caspase-3, which is the last caspase of the cascade, and it's labeled them showing that these cells are being killed and are undergoing apoptosis. So it's just a reporter of cell death in this case. So we're not manipulating caspase or CRISPR. We can use CRISPR technology also to generate different zebrafish lines or to manipulate human cancer cells. But I didn't show anything about that.
Just a small comment regarding caspase-3. It's a good indicator of cell death, but some tumor cells are lacking caspase-3 and they die. So we have to be careful on this.
Yeah.
Okay. Thank you, Dr. Rita.
Thank you.
That was such a wonderful talk. Thank you so much, Dr. Rita. Now I want to introduce starting the faculty talks, session 1, organizational research and physiotherapy. The moderator for this session is Dr. Prita. She has the mic over there, so she will introduce the speakers. I want to just notify one thing. We will stick to 13 minutes per talk, and we have a bell. So we will ring the bell at the end of 13 minutes like this. And then we will allow 3 questions and a total of 15 minutes per talk. So then we will do at the end of 15 minutes. Okay, so the mic is with Dr. Prita. Thank you so
Sorry,
much.
I don't like when I don't use my computer, things don't work, but anyway, sorry.
Very good morning, one and all. I'm Dr. Preeta Shetty, CRC College of Medicine. I'll be moderating the first session entitled Organizational Research and Physiotherapy. Under this session, we have 4 speakers, and each speaker will be allocated 13 minutes, followed by 2 minutes of question-answer session. The first speaker is Dr. Mohammad Rabashed. Dr. Mohammad is Associate Professor in the Department of Medical Imaging Science, College of Health Science. He is also the Program Director for BSc MIS program. Dr. Mohammad has a PhD in Medical Imaging from University of Sydney. The title of his talk is Enhancing Detection of Medical Images Using Dynamic Cues Algorithms and Human Visual System Sensitivity. Dr. Mohammad, your time starts now.
Thank you very much for the introduction. Also, I would like to thank Professor Salim and his team for accepting and selecting my talk. Professor Rita, it's really hard to follow after your great talk. So thank you for this great talk. Usually when we give a talk about perception and image processing, this is a very difficult task for radiology professional. So today I think it will be more difficult and more challenge because we're giving this talk for non-radiology professionals. So I'm gonna talk about detection of a breast cancer using dynamic cue. So now we are shifting from therapy to diagnosis. Is this working? It's not working. Okay, first of all, I would like to acknowledge my co-author, Professor Pablo from the Catholic University of Chile. So I will start about the motivation. Human visual system is a powerful tool to improve the image perception and the processing. Here I want to ask you, can you see a square here? Yes? Okay, sorry. Thank you. Here, now you know the trick. There's no circle. This line has the same length and these lines are parallel. This proves how human visual system is powerful in enhancing the image technology. Nonetheless, it's failed with certain tasks. For example, when the object too small, like microcalcification in mammogram, or when the object has similar texture with the background, similar to the masses within the mammogram, or when there is a noise like density, which masks the appearance of the cancer. For example, this cancer here, this cancer here, you can see this is a microcalcification. When we enhance the image, this is the cancer as we can see. So this is really tough. I will show you how difficult the task for radiologists and why we need to help the radiologists in detecting the cancer. We used to play this game. This analogy, you need to find Wiley. If you are not familiar with this game, simply what you need to do to find this guy with red stripe and hat in the head. So this is exactly how the radiologists search in mammogram. They try to find a very similar features with only very small differences. So if we go back to our image for a few seconds, because I have a very limited time, can you spot the Wiley here? I think he's just hiding somewhere here. This is how difficult the task. However, in mammogram, even with this difficulty, if we go one by one, at the end, we will find our target. But in the difficulty in mammogram, we don't have the beauty of colors. We don't have these colors. So it's this, we have only grayscale image. So this is difficult. Again, with the grayscale image, if we go systematic as what less experienced radiologists do, at the end we will find our target. But the main problem in mammogram, the prevalence. In mammogram, in screening population, in every 200 cases, only one abnormal. Imagine you have a book of Wileys with 200 pages and only one page has a Wiley, and I ask you to find. This is how difficult the task for the radiologist. So we need to find a way to help the radiologist. The first solution, computer-aided diagnosis or artificial intelligence. However, this is still underdeveloped. It can work for certain tasks, but doesn't work for others. So we propose to keep the task for the human to the radiologist, and we give a cue or help to the radiologist. That's why we called it dynamic cue. So again, let's talk about human visual sensitivity. As I mentioned, human visual system sensitive to the brightness, which is what we traditionally use in the imaging. Also to the colors. This is the brightness, so I can look here. There's some difference in the brightness, maybe skyphoid fracture or whatever. Colors, motion, which is the focus of this talk because we are talking about dynamic cue, and flickers, again, motion. If we try to help with the colors, we found it can create some artificial shapes that can increase the false positive within the image. So we propose to use flicker and motion within the images. So that's what I mean by dynamic cues. So we need to provide the help to the radiologist by giving them emotion within the image. I'm not gonna go through how we did it, but in the math lab we have an image. We introduce motion parameter multiplied by time, multiplied by motion function, then we end up with the movie. So we moved from static image, what we used to, what currently the practice, into a movie image or dynamic movies. Now, I want to prove this concept for you visually, then I will move to the experiment. Can you see any button here in the image? I guess, no. Okay, now, it's the same image. This is exactly what we did. So we have the image. No button was visible within the image, but when we moved it into a movie, you can see now the button. This what we mean by dynamic cues. So now we need to test this experiment in a clinical situation. This is our movies. We convert our mammogram into, as you can see, into a movie or dynamic cues. So firstly, when we look to the pixel level, if we take this line at certain points, we found something, even without looking to the image, there's something going on here in the pixel values. This gives us indication there is something in the image going on when we convert it into different brightness pair in the type. We recruited 10 radiologists, 5 specialists, 5 residents. We asked them to read the test set, include 124 mammograms normal and 20 abnormal cases. The test set from Japanese test set, if you're familiar with this. We measured ROC value. If you are not familiar with the ROC value is combination of sensitivity and specificity. So here's the sensitivity, here's the specificity. As we go in this direction toward 100%, it's higher performance. This is what we got. Now, as you can hear, here is the performance of the specialist, the radiologist, in the static images, which is the current practice. It's around the performance around 87%, which is concur with the most of the literature now here. Now, when we move to dynamic view, we can see significant improvement in the performance. We improve the performance of the radiologist by 6.5%. And for non-radiologists or the residents, we found very similar. They shifted from 80 to 89.8 with approximately 10% improvement in the performance, which is really significant. So as a summary of our result, we found improvement in the performance between 6.5% to 9.8%. So this is what we call the dynamic queue. Still work in the progress. We still recruit more radiologists. And usually at the very end of my slide, I give a message to take home. But since the audience not medical imaging professional, this is my message to take home. What's new today will be challenged tomorrow and might be obsolete the day after tomorrow. Thank you. Any question? Yes, Rashid. Yes, Professor. Please.
Can this apply to microscopy? Because in microscopy, again, you see pathologists looking to pattern.
Yes.
And the difference between static pattern and dynamic pattern. So if the cells are moving, the pattern may appear even under microscopy. So you are doing it in a
Yes.
sheet, but Sam here is doing static and dynamic, looking at cells and how they are moving. What you have seen the previous presentation. You think
I think, yes, I think it's work. We need to test it actually. We use this in something called digital pathology, which is very similar to microscopic images. So I think we can test it whether to see whether there is any signal, like maybe it can show some improvement or some sample within the image. Yes, I think it's a really good idea and good idea for collaboration, like imaging and digital pathology. Yes, thank you. Rashid, yes, Rashid.
Is there any other applications that could be applied in the medical imaging field?
Okay, actually, this very helpful for when the object too small and when there's a high contrast resolution, like the object has similarity, very similar to the background. Traditional example, as I mentioned, the breast imaging. Also pulmonary nodules. Now we are currently running the study in pulmonary nodule because in pulmonary nodules, very significant and it's hard to detect. Yes, Dr. Walid.
Now they are playing a very important role in imaging, especially in imaging.
Yes.
So I'm not sure about the movement. So I know that they're comparing the static imaging with whatever there, and they try to diagnose easily.
Yes.
So is there anything related to the dynamic for the artificial intelligence?
In fact, we did not test the thing about artificial intelligence. So you need a big test, data set. You need multiple images. We don't have anything. This is new. But why we developed this? I know that now artificial intelligence in the market, but still, as I mentioned, cannot work for every disease. And the main problem, legal medical implication. Now, at the end, the decision should be made by radiologists. So that's why we thought it's yeah. Thank you, Dr. Wade. Yes, Dr.
For mammograms that were free of disease.
Yes.
Did you find the experts with the dynamic
yes.
Imaging or with the dynamic diagnosed any of these normal as abnormal?
In fact, because we measure AUC or ROC, which is a combination of both sensitivity and the specificity, and the overall there was an improvement between 6.5 to 10. This tells that the radiologist has improved in both normal and abnormal. So I think it's less false positive with this model.
One question from my side, actually. A really nice talk.
Okay, thank you.
Yeah. Actually, the idea is what you are measuring is very fine dynamic cues you are taking that. Can we think about using multiple methods to measure that and reduce the false negative actually? Is it possible using multiple methods and then further try? Have you tried that?
Actually, we did not try it. I think it's a good idea to try. I can't say, I'm not sure whether it will reduce or not, but I think it's a good idea to test it and to see whether it can reduce the false negative. Yes. Yeah, thank you. Maybe we can talk about it later. We can maybe collaborate. Thank you.
No more questions. Okay, thank you, Dr. Mohammed, for a wonderful talk. And this work of your dynamic cube algorithm will help the radiologist to perform better, especially the new radiologists. Thank you so much. The second speaker is Dr. Rana Sudhir. The title of his talk is Who Are Responsible Scholars? Roles, Practices, and Future Research Agenda. Dr. Rana is Associate Professor in College of Healthcare Management Economics. He has taught at FIIB Delhi and IIM Nagpur. He has launched new academic programs and journals. He is Editor-in-Chief of FIIB Business Review and South Asian Journal of Marketing. He has a number of publications in business research journals. May we have you, Dr. Rana? Yes. Dr. Rana, you're allotted with 13 minutes plus 2 minutes of question answer session.
Good morning to all my dear colleagues. Well, it's a little challenging to open the debate on an ambitious and controversial issue. I'm not going to talk anything different yet. I thought that I should say some of my experiences that I earned in the recent decade, and especially during my PhD when being a young scholar, getting into a publishing side, trying to open up new doors for the scholars who come into the emerging marketing areas, and then learning new things time by time, and then thought that, yes, these can be useful to some of my fellow colleagues. So I'm just sharing something that I have learned over a period of time, and I'm trying to conceptualize it to put forward so that it can be used to foster some research orientation. And specifically, my idea is not to pinpoint the academic practices. Being an academician and scholar specifically, we feel proud, we share number of academic excellence for our contributions. So idea is not to look at the critical side of the academics and research. The idea is to see that how this stream has made more progress on getting questions than on getting the answers from the research side of it. Like I said, that the idea is not going to be critical yet. I'm sure you must have heard some common noise in the academics all across the discipline, though in business academics it is little more, but I'm sure your field is also touched upon these, that there are highly celebrated authors who publish 100 plus papers a year. There are journals who publish 500 papers a year and still index really well. There are ethical, unethical ways of getting published in the research journal. So these kind of things are very, very common. So my idea is to look at what are the research domains that can come to us where we can deep dive and see and understand what the true picture is. The true picture is whether to see that, oh, if somebody have published largely into specific journals in specific area, actually is a responsible scholar, or somebody who is trying to create a difference and by having less number of publication is a responsible scholar, somebody who is having an ethical orientation and conducting doing that research is responsible scholar. There can be different meanings. So what these different meanings mean to me and the other scholars who have opened this debate is my idea to collate and see that how certain things can help somebody who start their research journey or in the midway to balance themselves as a responsible scholar. As you see that there have been a lot of research published, especially into the last decade, stating what ethical research is, what ethical conduct in research is, how publishing is working, how predatory journals are coming up, and lot many questions. The question that came to my mind is, whose responsibility is going to be to put it forward and open these debates? So I'm one of those. What do you think? Who are the responsible scholars? Only those who conduct research ethically, or something else also come to your mind? The guides? Okay, so guides are responsible. Whom you think are the responsible scholars? Now, both guides, students, everyone? If everyone is a responsible scholar, then why misconduct is happening? So, I mean, you look at the ethical side of it, you look at the orientation side of it, right? Anything else also come to your mind? Publishing houses, their collaboration, okay. Expectation, okay. Does it also come to your mind that novel contributions, more additions into the knowledge, looking yourself as a thought leader, that also come to your mind when we talk about responsible scholar or responsible scholarship in the field? Okay, this is how did I conceptualize. I'm very proud and happy that I generally debate on the conceptualization in my domain, and there are different scholars at global level where I also contradict and debate with their papers. Especially, I would like to acknowledge a few of them, like Jokola is one, Macklins is second, then Hewland is third, and then I started debating that how I should be given, I mean, we as a conceptual thought leader should be given a chance to put forward our view and conceptualize things rather than having empirical evidences, because at initial stages, we can't have empirical evidences. So this research is a conceptualized research where we tried to define responsible scholar and life of a scholar into certain fashions. So was like philosopher, a bellwether or the institution builder, to a community builder and a facilitator and mentor, a problem solver, a gatekeeper, or a writer and reader. So responsible scholar act into multi scenarios in multi hats to fulfill their responsibility toward their institutions, towards society, to self, and to the community as whole. Maybe if you would like to answer this question, that how management is different, how we in management academia are different than other domain scholars. Okay, the beauty of our domain is that we are multidisciplined. We have collaboration coming from different disciplines like mathematics, statistics, economics, psychology, geography, history, and so on. And in fact, English, communication, so literature, a lot of things that come from different domains, not specifically from management. Second is that it is not a content-based domain. And this is the most beauty. Management is not a content-based domain. It doesn't work like your physics, chemistry, or biology. We are more of a perspective-based domain. For example, a HR manager, what issue he faced on the conflict of two managers, every HR manager is going to solve it differently. So it's more of a perspective-based. It is not a content-based. And third is the context influence is more on the management issues. So what we are going to suggest is we suggest scholars to have their own philosophy of doing research, because satisfaction matter a lot and everybody need to fix up their own goals. These are some of the papers that I come across and shortlisted, that why philosophy has to be there in a scholar. So before you think yourself as a scholar, you need to be a philosopher. And maybe some of these can be useful to you. I can share these if you like to read anyone, but something that I come across really, really interesting is scholars before researchers. Many times we start our journey as a researcher, thinking about making research questions and then testing those and then putting forward more research across it around it. But we do not really create our own research philosophy. Why am I doing it? And having more questions of deep diving, why? So having a philosophy can actually make you more responsible, passionate towards your research. Well, like I was thinking, like we were debating that how responsible research is going to be useful. Well, you may find that impactful research is being responsible, ethical conducting research is being responsible, or making a distinguished contribution in the field is being responsible. But you may like to understand that how responsible research really works. It is that also delivering responsibility on organizations to take decisions based on your research. And if there is anything that I am not bringing the real perspective on the research, not just because of the publication point of view, so that it can act like a guideline or a path maker to policy makers and decision makers, then also I'm running away from the responsibility in my personal greed to have a publication. So that may also be there. And it may also relate to the innovation, that how responsible research and innovation are related to each other. It is always going to be an unfinished journey. So you may like to see that responsibility is never going to be accomplished. And every time you keep on moving from one step up the ladder to another one. So it continues. I work more on literature review side. In fact, 2 years ago, I launched a new series in Emerald, which is known as Review of Management Literature. Had got a very warm response on it by the author. So I understood that you can responsibly contribute new knowledge in your area if you have a habit of critically evaluating the literature that exists. So you may like to see new techniques, new ways of critically evaluating the literature. There are different ways of evaluating the literature, and these are some of the celebrated papers in our area. Maybe can be useful to you to see that how they did, what kind of a technique they opted for. Last year, we also contributed one framework in this queue with my dear friend, Dr. Singh. And we also, we debated that how do you bring more power, differentiation, and make it more impactful. Well, there has been a lot of criticism regarding authors and editors. And being one, I faced a lot of challenge because one, I was very young when I started. And second is that even if you have done work and you have published, people think, oh, he has published just because of it. And second is that there is a very strong community lobby, whatever you say, that people use connections of each other. So it happens, it works, it is there. Like human beings play human practices everywhere. But at the same time, if you really want to understand that why it is working, how it is working, you need to take an additional pain to go a step ahead and then see how it works. So you may like to see that what are the obligations, how do you write an effective referee report if you want to be a part of the community, and how you become successful author, because it is also there that successful authors are successful reviewers
Dr.
as well.
Rana,
Yeah,
you're
I'm
running
going
up.
to summarize. You need to understand the anatomy of being an impactful scholars, because there is also a debate that more citation, they show the impact, more reading show the impact. So that is there. You may also like to see that how do you celebrate the impact, what are the thoughts that make a paper interesting. And especially, this is my favorite paper, by the way, that when I write my masterpiece, this paper have taught me a number of things. That how do I reiterate on my ideas, how I make it more impactful, what is that I should put forward. And more specifically, especially to my young students here, plan your academic journey. If you're going to be a part of academia, you want to pursue your research career, you must know that where your schools are going. I read some of these papers and these have given me fabulous ideas of a good pathway. that where these B schools are going, what are their future, what are they planning, what kind of accreditation they are planning, what are their expectations from faculty member, what role you are going to play other than research and teaching, because presently you might be thinking that the only research and teaching is that you're going to do. It is not going to be so easy. There is a lot of work that will come to you. So you need to know that where your field and your institutions are going to be down the line from 10 years now, and plan yourself according to that. So these are some examples from B schools, because I belong to the same. And these are some of the unexplored areas specifically related to the ranking and impact, because this is a hot trend nowadays, that how it is working. You may like to explore on impact metrics, to ranking of schools, to repetitive publishings, and then research in recruitment, progressions, how it is working, how inclusive policies and capping can be made, how academic pedigree can play a role in publishing, because it is also debate that people belong to the top institutions have more chances of publishing and getting settled into academia. So you may like to see, and you may ultimately like to see that where your journey, your role get fit into the community as a transactionist or as a mentor or a community workforce. Thank you. Your suggestions are most welcome.
No, Dr. Rana, we'll not allow question answer session because you have deprived the audience of that time. So if anybody has any questions, we'll contact Dr. Rana during the break.
Sure.
Thank you, Dr. Rana. Yes, the third talk for the day is, the third speaker is Dr. Jagrup Singh. The title of his talk is Supply Chain Resilience Strategies and Their Impact on Sustainability, an Investigation from the Automobile Sector. Dr. Jagrup is Assistant Professor in Operations Management in the College of Healthcare Management and Economics. Dr. Singh has a PhD in Financial Assistantship from India. Dr. Singh's research interests are applications of multi-criteria decision-making techniques, supply chain management, healthcare operations, ergonomics, and aviation sustainability. Sir, your time starts now.
I will be odd one out. I will from medical background. Yeah, actually, the battery was a bit low. I could talk. Yeah. So my topic is supply chain resilience and its impact on sustainability. When COVID came, so other than the term COVID-19, another term was introduced to all of us or throughout the world, that was supply chain. Every one of us, even if we have not faced any shortage of any supplies, but still we were afraid of having shortages of supplies, right? So I have divided my presentation in two parts because this might be a odd term for medical professionals. So first part, I will be discussing about supply chain, and then I will be presenting my research work and the outcome of that research. So if we talk about supply chain, anyone who can tell me what supply chain is? Yeah. Okay, it starts from producer. Yeah. Yeah. So majority of us might be thinking that it is from producer to the end user, but it is not just from the producer, it is from the other rear end. There may be 3 tiers, 4 tiers of suppliers who are supplying the raw materials or those ingredients to the producer, and they are putting it together, and then that outbound logistics will come into play, and those will be supplied to the customers. So supply chain has revolutionized through this time period. If we will see the first revolution of supply chain, that was in 1920, we call it as Ford supply chain. So what was Ford supply chain? Ford, all of you might be knowing about Ford. Yeah. Have you seen this car somewhere in movies or somewhere? Yes. So the Ford came up with an idea of manufacturing or assembling a car, and what they were doing, they were having all vertical integration throughout. They were the one who were extracting the raw material, they were the one who were preparing the sheet metals, and then they were delivering the cars to the customer themselves. So this vertical integration, what they gave them, that high efficiency, and this is termed as the most efficient supply chain till now. And then the limitation was that they were saying that, okay, we can provide you everything, all type of car, till the time it is T model and black. So the limitation was that there were no variety for the customers to choose from, because that was a new era for cars, for car market. So they were only providing one product. Then in 1960 came your Toyota supply chain, that is termed as the second revolution. So what Toyota did, that rather than going by the efficiency or going by the vertical integration, it developed a pool of vendors and procured the material from those vendors, and then have a product mix and offer the variety to the customers. So limitation of, obviously they have lost some efficiency to the, like Ford was enjoying. And then we came up with the third supply chain revolution, that was a Dell supply chain in 1990s. So by that time, the internet was evolving, it was new to the market. So rather than manufacturing and offering the products to the customer, they thought that, okay, we should be providing customized products. So first case, we have efficiency. The second case, we were having variety, but with variety, customization was not available. So Dell started offering customization, and they did it through delayed differentiation. Like they were not assembling and putting the products in the stores, but they were assembling it only when they were receiving the orders. Then later on in 2005, they realized that, okay, this may not be a feasible model. Majority of customers, they are looking for those standard configurations. So they came up with the brick and mortar model also. So like we have seen in these three scenarios, often the supply chains or the companies, they are competing between two situations. One is the efficiency and one is the responsiveness to the customer demand. So there is a trade-off when we go for the responsiveness. Obviously, you have to give up some efficiency, and if you will look for efficiency, you have to standardize your processes, and obviously you will be less responsive to your customer's demand. So whatever part of your supply chain you might be looking at, it is transportation, inventory, or facilities, everywhere this trade-off is going to work, and you have to manage it. And then there came a paradigm shift in the supply chain approach. The first shift was your lean supply chain. So lean was when you try to improve the efficiency, like it came basically from the Toyota system. Whatever waste you have, which a customer will not value, they try to minimize it, whether that is transportation, that is excess inventory, that is over processing, that is overproduction, that may be motion, unused skills. All those are considered as waste, and they try to improve the utilization by minimizing the waste in the system. Then another term or a supply chain paradigm came in existence, that was a green supply chain. As we all are aware about the sustainability concept that evolved from here. This one concept came into existence in 1987. And then we have a sustainable supply chain, or nowadays every term, every process we are following, we are trying to emphasize more on the sustainability part. So sustainability, rather than just focusing on the environmental aspect, we have started focusing on the social aspect as well as the economic aspect of the organization. If they are not earning profits, they can't be sustainable anymore. So this is termed as a triple bottom line of supply chain, and that was given by Ellington in 1997. That term, although this concept was recently withdrawn by Ellington himself in HBR, but still it is very much relevant till the time we get the next advancement to this approach. And there are many sources of disruptions to the supply chain, and COVID was one of the main disruption or uncertain disruption which it has caused, and this has led to the shortages throughout the world. And when COVID came, every organization at that time or every supply chain was focusing more on efficiency and more on this green or sustainable aspects, but they have somehow forgotten about the resilience part. So now supply chains have also started working on the resilience, and as per a survey by the Gartner, majority of the organization, they feel that, okay, epidemics and pandemics are significant risk to their supply chains, or we can say the uncertain events. Uncertain disruptions can hamper their capabilities and they can halt their operations. Another second one is the shortage of critical raw material, and third one is shortage of supplier production capacity. And if we look at this chart, so majority of the companies, they say that, okay, they are not resilient at now, but they would like to improve their resilience in the coming times. And the area of my research or the sector which I have chosen for this research was automobile sector, and specifically for Indian automobile, because that is one of the major sector which has major variation during this COVID period. Because of shortage of supplies, they have almost contribution of 7.5% in the India's GDP. And whereas while making this contribution, they were relying more on the supplies from China, and that 30% of the supplies were coming from China. During COVID, they could not survive that period, and now they are looking for the resilience that we have just discussed. So it is ability to bounce back. If you are robust enough, you will not be harmed by those disruptions. But resilience is more about developing that robustness in supply chain. If you will go by literature, sometimes these robustness and your resilience terms, these are used interchangeably, but there is a small difference between both terms. Resilience is more about developing that capability. So my research objectives for this study was to identify the strategies which can improve the resilience of supply chain, and then which combination of strategies or which strategies are more important or more relevant for that particular sector. And then many times when we go for resilience or when we go for sustainability, like we have seen in the previous slide, people compromise the other part. If they are going for sustainability, they compromise on resilience because they can't have efficiency with the resilience part. And if they are going for resilience, they just skip the sustainability part. But literature states that, okay, if you want to be sustainable, you have to be resilient. If you want to work for a long period, you have to be resilient. And then my fourth objective was which supply chain resilience strategy has maximum contribution towards sustainability. So this was the framework which I have proposed in my study. So we have sustainability, the three dimensions or the triple bottom line of sustainability. That is social dimensions, environmental dimensions, and economic dimensions. And I have, based on the literature and then using the Delphi techniques, discussing with the experts from industry and academia, I came up with these 6 strategies for building resilience of automobile supply chains. So the first one is collaboration. So collaboration is basically a system approach where every contributor of that supply chain, every stakeholder of that supply chain have shared objectives, and they are working towards the same common objectives. The second one is collaborative technologies, which we have advanced technology which can improve your ability to produce as well as the transparency throughout your system. The next one is circular economy. Basically, till now, what we are doing, we are consuming, we are taking material, we are consuming and then putting it to waste. So circular economy is encouraging the reuse, recycling, and reducing the use of components. Then we have reshoring, like we were just discussing, that just to have that contribution, we shifted to lean practices. Those were maybe sometimes offshoring, globalization. So those things, what they have done, they have moved the facilities away from us. So the fourth strategy is reshoring. Next one is diversified multi-sourcing. Many of the companies, they were relying on one source. They were only one source at each stage. And when any disruption occurs, they were not able to continue their processes. So the strategy which literature sometimes states, they say multi-sourcing. But during COVID, we also realized that many of the facilities, although companies were having multiple suppliers, but those suppliers were in the same region. So if you are not diversifying your suppliers, then also you are at the same risk. The last one is building redundancy. This is against the sustainability concept or the environmental sustainability, but it is required for the resilience. So this is my proposed research methodology, which I have used. So first stage is a review of literature. Like I said, in second stage, I have prioritized those 6 strategies. This is basically a qualitative study in which I have used best first method. And in the next phase, we have gauged the impact of those resilience strategies on the sustainability dimensions. And based on the best first method, so these are basically the priorities. And if we look at the weights, what we have attained, so collaborative technologies and collaboration are the two main contributors. And the last one, if we will see, so circular economy is having minimum weight. And these are the impact. And if we look at these impact of these collaborative technologies on your sustainability dimension, so it is maximum on the economic sustainability. So from this research, we came out with a final conclusion that it is more about supplier and manufacturer relationship. If we can have better relationship through the use of technology and through developing trust between them, so it will be better for the whole supply chain. So I'm just skipping this part. Thank you.
Thank you, Dr. Singh. And we will take the question answer during the break.
Yeah, sure.
Thank you so much.
Thank you, ma'am.
No, ma'am, because we are running out of time, we will take the questions during the break. Dr. Jairoop and also Dr. Rana's question. Okay. The last speaker of the session is Dr. Waqar M. Naqvi. The title of Dr. Naqvi's talk is Impact of Gamification versus Conventional Rehabilitation on Pain, Range of Motion, Muscle Strength, and Functional Independence Post-Digital Radius Fracture. Dr. Waqar Naqvi is Assistant Professor in the Department of Physiotherapy in the College of Health Science. Dr. Naqvi has more than 172 peer-published research articles, which include 6 patents, out of which 2 are granted and 4 are published, 12 copyrights, and 3 textbooks in his name. Now we have Dr. Naqvi. So your time starts now.
Good morning, ma'am. Good morning, everyone. I won't take much time. I'm taking a part of my PhD project in front of you all, and it deals with gamification. Do you know what is gamification? Any idea like about having gamification? What are games? Gamification.
Something to do with game.
Yeah. Yeah, it is useful now. The thing is, gamification means when we use gamification as a part of our therapy or any treatment or any evaluation in healthcare sciences. That is what gamification is all about. It has been widely said before, like I think you have taken the old slides for, okay, that's fine. So I'll just put up in the proper timeline. This is the time of metaverse where we are dealing with a lot of things with new technologies, especially in the healthcare sciences. We are now seeing, like when we started this session, Dr. Ravadesh was absolutely wonderful in MedLab. It came into health sciences. After that, we heard Dr. Sudhir Rana. He was totally into the scholars and all, even sustainability model. So if we connect all these 4 models and even the starting talk with the precision medicine, it is interfering in each and everything. The AI, the metaverse, the artificial intelligence, the augmented reality, the virtual reality is now becoming a very much important segment in healthcare sciences and healthcare management. So if we see now in metaverse, in healthcare sciences, it is going from radiology. There are a lot of good projects, like Dr. Ravadesh will be knowing it. Even the AI, Dr. Vinay sir is there for it. We can see like how it is going embeddedly, properly into the healthcare sciences. It is also going into medical education and training. There are a lot of new technological ways of even writing the papers, predicting the papers, and doing everything like as a chatbot. Like even we can see now publications. ChatGPT can do work with the publication. It is a part of it. Students are using it, right? But we also got an anti-plagiarism software for ChatGPT now. So the thing is like, it depends how we are moving into it. And we feel like we are blessed to be into this phase where we are trying to explore the AI, the metaverse, the artificial intelligence, not only into one domain, but into the complete healthcare sciences. My project is a small part in which I try to see as a physiotherapist, like, can we have certain things which we can contribute to the society? Can we have certain things in gamification, artificial intelligence, virtual reality, augmented reality? Will be helpful for the patients? So we try to see how we can help with that. Now, if you know or don't know about, in TPTR also, we are having a very big lab of virtual reality, but we still see a very less patients there. Physiotherapy, if you see, it is a very tedious, it's a very taxing, and sometimes it's very boring for the patient. But when we see in physiotherapy, most of the patients, either they are pediatrics or geriatrics, and both loves to play games. They both love to play games. So what we did, we tried to figure out, like, let's say we can have some smaller population, like distal radial fracture, which is very common in physiotherapy. Like in every 1,000 of the patients we get, 4 patients are of distal radial fracture. So we thought to just check the efficacy of gamification using Oculus Quest. We know Oculus Quest, people are using like head-mounted gear now, they are playing games. Even Netflix, even everything, you can watch it from there into 360-degree view. So we did a small research gap analysis, like how the gamification can be very useful for the distal radial fracture patients. So when we did a research gap analysis, we found that there are empirical gap where we are not able to find a proper research which has a proper investigation done on that. Every research, every study has a proper baseline, and that baseline is a research gap analysis. Unless and until it is not strong, research is not strong. That is also one of the responsibility of the scholar to understand the research gap analysis. Unless and until the research gap is not strong, the research is not strong. We need to also have the practical knowledge gap with about our experience. We also should have a knowledge gap. So when we summate everything, we found out, like, okay, let's try a patient with distal radial fracture with gamification, distribute into 2 groups. We had 146 patients, and we divided them into 73 and 73 just to check. So we did a randomized control trial that was superiority based, single arm with 73 into each group. We did a proper allocation. We did a proper allocation of the sampling and everything. What we found before into the research gap, like the physiotherapy is tiresome and tedious. It needs more longer treatment. There is a problem with the motivation for the treatment adherence and the patient compliance. That is a very big issue in physiotherapy. If a patient, we ask them to come for 7 days or 8 days, and if they get relieved, they will not come. Even we, if we get relief from the pain in 1 day or 2nd day, we won't go there, like, because now we are relieved with it. In gamification, it is much more immersive. It is much more motivating because it follows a behavioral approach also. It also standardizes the quality of treatment. There is a precision in motion tracking and accuracy. If Dr. Ravadesh will be knowing it, like gamification or motion sensing or AI, they are much more precise. After some days, they are going to diagnose everything. Like the MedPalm and everything, the chats are coming up. They are going to diagnose and take everything. We are just going to see the things, is it correct or not? And the last thing, it is more recent and more ascent. So our main objective was to see how it can be helpful for pain, range of motion, muscle strength, overall working on the functional independence on the patient. When we are dealing with the upper limb, it needs a functional independence. We cannot keep it idle. So whenever we work with a patient as a physiotherapist with a rehabilitation purpose, we always see like we deal with the functional independence as whole. So in methodology, we did a randomized control trial with 146 patients, and it was computer generated randomization. We used pain, range of motion, grip strength, and functional independence. For that, we use the measurement like visual analog scale, universal goniometer, which measure the range of motion, jammer hydraulic handheld goniometer for the strength, and the DASH questionnaire, that is disability of arm, shoulder, and health questionnaire. We also used Oculus Quest, which is very economical. Even in UAE, it is either like 1,200 dirhams or 1,500 dirhams. Television screen, whirlpool bath, that is for the aquatic therapy also sometimes in physiotherapy, TheraBands, dumbbells, and softball. We followed everything with the concert guideline, like the basement assessment, the basement evaluation, then after 2 weeks and after 4 weeks. So we used gamification properly with a framework. We always see the mechanics, dynamics, and the aesthetics related to the game which we are seeing. Since it is gamification, it is serious gaming, we have to be adhered with the objective, like why we are taking this game. So there is a standard framework for that. Even now, Equator has developed a guideline on gamings. They have a proper checklist. Even when we try to publish the paper, the editors are here, like they know we need to have a proper checklist. So this is one of the game we use. This is known as Racket NX. And the second game we use, it is a Holofet. It's so easy to get and just to try. So in the B group, we had a proper conventional physiotherapy consists of therapeutic whirlpool, joint mobilization, range of motion exercises, and the fingers exercises. In analysis, I'm going to summate it much more faster. Like when we see, obviously, we are going to see an improvement in everything. Every researcher is going to see like improvement in everything. So there was an improvement in pain. It was the improvement in wrist of flexion, wrist extension, radial deviation, ulnar deviation, forearm pronation, and forearm supination. And even the grip strength, we find out it increased superbly with gamification as compared to the conventional physiotherapy. Even the dash score got improved. So when we check this thing into a 6-level hypothesis testing, we saw a critical value. When we started this project, we did a small pilot study. It's always better to do a